Thank you to the organizers for inviting me today. I'm so happy to be here, and I think I almost learned more from you guys than you're going to learn from these 15 minutes, but I look forward to a good discussion. You can see my screen, right? Oops. So I'm going to start off with just something that you've all been talking about, but the fact that we have, I don't know why this keeps changing, that we have sickle cells that then go into the blood vessels and cause a lot of damage within the blood vessels. And of course, this affects all the organs in the body, some more than others. And you've discussed a lot about the impact that it has on your life, starting with the pain, but also not to forget those organs that pain, but still have a lot of damage along the way. And this little panel down here is just just to show you that a lot of people have been working on how to make this better, which is how all our treatments have come about. There are a lot of molecules, there's a lot of chemistry behind this that has been at work, trying to figure out how to make things better in the long run for patients with sickle cell disease. But what we know is that it affects every part of the body. And over here, those in green are the chronic complications that happen because of long-term damage. And those things in yellow are all the acute complications that we see that are part of sickle cell disease, that are known and recognized as part of sickle cell disease, that your hematologist, as they track you, will keep track of in addition to all the symptoms you have. And we've learned with time that the symptoms increase with age because as more damage goes on, it becomes more obvious that something is wrong with a particular organ. It also, the reversibility depends on the extent of involvement, organ damage involved. And it may be influenced by, so when we talk about curative therapy, as we've talked about so much in the last hour, it's maybe influenced by complications that are associated with the therapy. So there's a balance that we're talking about here, disease versus the therapy. In general, we think of early symptoms as happening between sort of 3 and 13 years. I am a pediatric transplant physician. We do both sibling donors, unrelated donors, and haplo transplants. But we do realize that between 13 and 25 years, there are more established symptoms, and then into adulthood, there is worsening organ damage. So the timing on when this disease is sort of it complicates your life will change for every patient because the severity is not the same between different individuals, as you know. So my mission today is talk about the effects of what to do after a curative therapy is done. And to try to understand that, I wanted to just discuss this table here. There is transplant, as we've talked about, there is gene therapy. There are different kinds of transplants, as we've already talked about. There are side effects, as we've recognized from each of them, and there's sort of the intervention, if it can be changed or reversed or not. So everyone who goes through a curative therapy has to go through the conditioning agents, because you can't get that transplant or gene therapy done without exposure to that kind of conditioning. There are some modifications that have been made in the transplant arena just because it's older. And there are modifications that I'm sure are going to come up for gene therapy to try to make these conditioning agent exposures better. There is immune suppression that comes with transplant, because unless you decrease the immune system of the patient, you're not going to be able to get the new immune system in. And of course, that sets up for infections, and that needs monitoring and prompt treatment. Whereas gene therapy is the patient's own cells coming back in, autologous as we call it, and that immune system recovers faster. It does drop, but it recovers faster. Graft versus host disease, we've talked about. When a new immune system comes in, it has to learn to live with a different body. And until that happens, graft versus host disease is an issue, treated with more immune suppression. Inadequate cell dose. So we could put in cells, but they could be rejected because the body doesn't take it. Or even the collection of these cells may be difficult. If you want to change your own cells, change them genetically and put them back, might run into trouble getting those cells. And then the eventual long-term cure, as we know it, requires stable expansion forever, for a lifetime. And so a late rejection would only result in more disease. And so strategies to deal with that late rejection are also under investigation. So this is just to show you the benefits of what we know mostly transplant can do. Again, like I said, transplant has been around longer. We do know that there is a burden involved in terms of caring for your disease, in addition to the quality of life changes. We do know that transplant is quite intense and quite an issue when going through it. So it requires a lot of inpatient stay and medical care. The goal is to make it better with time, longer term. And this actually is a publication from Dr. Shea showing that after successful transplant, the use of medication for pain goes down, but it goes down really slowly depending on how bad the pain symptoms were before. And so it's not an overnight cure, and it takes time to settle in and get better. But going through a successful transplant, as in this publication here, does improve eventually physical functioning, general health, and so on, as long as the transplant has been successful. And over here, this is gene therapy in the bottom right corner, showing a lot of pain episodes before the gene therapy, and then how there's a significant change after successful therapy has happened. What is not quite seen, but what needs to be tracked, is what happens to all those organs that are hiding inside the body. We're talking about the brain, the lung, the heart, and so on. And so those can be followed with some of these follow-up sort of schedules that we have for patients. We've realized that the IQ stabilizes because the brain is not under an onslaught of blood vessel damage anymore. And then that the brain perfusion and oxygen delivery improves and gets back to normal once you take the sickle cells out of there. So these are sort of the unseen or unfelt changes that are important to track as well, that I'll talk about. So coming to the therapy itself, the conditioning, the immune suppression, the graft versus host disease, and so on, we do know that if you take this line, this dotted line, as sort of your standard of none, The side effects, such as on the heart, for example, are worse if you're exposed to very intense conditioning, or if you have more graft versus host disease. They're also more if you are older. The younger patient potentially has maybe less damage on these organs, and so you can expect a certain level of increased risk depending on age. And also, if you come in with a disease, an established disease in an organ, there is a possibility of more complications related to that because there's already some underlying damage. This is in terms of the brain. That can occur depending on what was there before. And there are some symptoms that are not expected to recover. For example, if you have avascular necrosis of the joints, neither transplant or gene therapy would change that because the damage has already occurred. But it can be tackled with other interventions such as joint replacement or just conservative care and management of such a joint. But this therapy would not be expected to make that change. So how do we maximize success? And that is by recognizing the pitfalls and also figuring out this assumes that you have taken the step forward towards curative therapy. And the things to think about are what happens to my disease? If the treatment is successful, what can I expect? What changes would be considered irreversible? What are my responsibilities to ensure success? What are my medical team's responsibilities? What do we have to do together to make sure that we encounter as few difficulties and the best success possible? How is success going to be measured and tracked? What are my options in the event of an unwanted effect or outcome? Or what are those unwanted effects that I should be thinking about? And what is the duration of follow-up expected after this curative intervention? What are my responsibilities and what are your responsibilities as the medical team in terms of follow-up? So I would say that we need to discuss these goals. We need to discuss the existing disease in terms of reversibility and control. We discuss the clinical trial context. What is the question the trial is asking? What is it going to, how is it going to look at follow-up? And last but not the least, what are the side effects that I will encounter? Fertility preservation is a discussion that we have with all our patients, given the intervention, given the conditioning that we have to expose patients to. And the effects of those interventions. And then post-intervention, the compliance and follow-up. Recipients will require regular, close follow-up. Early post-transplant or gene therapy, it's very important to do this very frequently to make sure infection is followed, GVHD is followed, hypertension, press. These are things that are anticipated side effects that we are very careful to try and avoid. Compliance and monitoring is essential, even if nothing is going on. So I want to say that even if everything is completely okay, you will notice that you go back into the hospital or you go see your doctor every week or every other week to make sure that nothing gets started up. And then outpatient contact and communication is so essential after, so that we can intervene and try to avoid a complication even before it starts or just as it gets started. I just added it at the bottom that when we can relax, you can relax too. But before then, we both shouldn't be relaxing. We should be paying attention to what we are to be doing. So the measurements that we do after intervention depend on the extent of the disease, and it encompasses multiple endpoints. Like I said, we like to look at clinical and laboratory markers of the disease. We like to look at the persistence of the graft, and then we also like to take care of questionnaires so that we look for patient-reported outcomes, we look for quality of life, we look for healthcare utilization. And I'll come to the sort of endpoints or the monitoring that we do in the next few slides. And then we also need to cover the toxicity measurements of the intervention itself. So are people more prone to what's called posterior reversible encephalopathy? It's a drug-induced disease that we need to avoid. Is there iron and liver-related toxicity that we need to care for? Is graft versus host disease setting in even if we try to prevent it? And should we go ahead with treatment? Are there late complications, endocrine, gonadal, that we need to tackle? So all these become important follow-up features after the intervention has been done. Over here, I have three that I sort of want to show. We do monitor the central nervous system both by imaging and by measures of cognition. We want to make sure that functional capacity, attention, memory, function are well taken, are monitored, taken care of, intervened if necessary, and we look at these measures on a regular basis. Imaging measures, such as a brain MRI, and the first one there shows you normal tissue. The second there shows you the arrow marks point to where there was damage from sickle cell disease, and this ought to be tracked in the long term. And then there are questionnaires, like I said, for quality of health that we track, and it's things like a pain diary, things like outcomes that have been put together nicely by the NHLBI in the form of questionnaires you can take depending on the age of the patient and track how these interventions are doing in the long run after they've been administered. And then come all the organs that I talked about. The laboratory tests tell us how the absence of sickle cell is doing within the blood. And then we look at lung function, heart function, and kidney function. And each of the things that I've listed below are some of the tests and measures that we use to determine how these organs are functioning long-term. Are they affected? If they are affected, is that effect getting better? Are we making a difference? Do we have static disease? Do we have reversible disease? These are things that we track in the long term. Some of the other organs that I haven't included in here are listed below: the eye, the joints, the testicular function, the chronic pain, the liver, the iron load, etc. As you can tell, this is a whole body follow-up of everything that we know could have been involved, either by the intervention or by the disease, and then tracking it long-term. And so from the transplant perspective, or from the gene therapy perspective, we want to look at in the long-term regimen-related toxicity. Are any organs affected by what we exposed a patient to? What's the immune recovery doing 3 months later, 6 months later, 1 year later? When is it okay for us to say you are not at risk for infection after the intervention anymore because we have re-immunized you and we know that your immune system is up and functioning well enough? Graft versus host disease, which can affect almost any organ in the body. When can we take a patient off immune suppression in the case of transplant? And then the medication-related toxicities, obviously, the fewer the medications, the better. Up front, there are a lot of medications we have to give to prevent infections, graft versus host disease, and so on. And we expect these to come off with time. And that time depends on how a patient does as we track a patient along the way. This is just a, not that I want you to read this, but I want you to know how we track our patients. This is a follow-up schedule that we have for everybody: lab tests, organ functions, supportive care, and at what time points we follow them. And we do this regular check as patients come to know when we're doing what here, so that we can track outcomes and recognize outcomes that we have to treat as soon as possible, which is an important piece of follow-up that is required after any kind of intervention like this. So in summary, I want to say that success is tracked by clinical evaluation, laboratory tests, organ function testing, and patient-reported outcomes, which I didn't put in here, I should have. This should occur in a systematic and serial manner so that problems can be tackled as they arise and sort of fixed before symptoms or damage can occur. Communication channels between the patient and medical team are so essential to make this successful. And I say this because a lot of times I'm in pediatrics and we are relying on the patient, on families, as well as the medical team. And the medical team doesn't mean the doctor and the nurse, but also means our physical therapy, our child life people, our social services. Everybody works in a team to help make this successful. And then these serial measurements will help patient outcomes and inform regarding, improvements that we would never have been where we are now without the improvements that were done along the way. And then follow-up clinics dedicated to curative therapy and follow-up are becoming much more common in all institutions, where all aspects of follow-up, medical, functional, occupational, reintegration back to a normal lifestyle, are tracked very systematically so that we can help patients as in any manner that is needed. I will end there. Happy to join the discussion later. I just want to thank the village, as I call it, out here on the right, where it's a triad, right? It's patient and families, it's a sickle cell team, it's the interventional curative therapy team that work together to make all this possible. And thank you very much.